you for the IVU and for Dr. Addai for having me this morning or this afternoon as it is in Ghana right now. And my talk today will be focused on kidney cancer and specifically kidney cancer with IVC involvement. Hopefully some other time we can go into some other topics on advanced kidney cancer, but I thought it would be nice to do just a talk and then have a couple of cases. And I think it might be better or easier if we do the questions during my talk. That would be less formal since there are not many people. If you don't mind that, you can stop me at any time. Since we have another 50 minutes, we have enough time. Just feel free to stop me at any time, please, and ask any questions you have during the talk. I think that'll be the easiest, if that's okay with you. These are my disclosures. And again, the talk today is going to be on IVC thrombus and kidney cancer. And just to revisit a little bit the staging system, this is what we use generally for diagnostic purposes, or when we are doing a patient chart, we use the AJCC staging. And just to remind you very briefly, T3A is tumor in the renal vein or in small vein branches. T3B is a true IVC thrombus that's generally below the diaphragm, and T3C is either a tumor thrombus above the diaphragm or a tumor thrombus that has IVC wall invasion. However, for surgical purposes, when we're in the operating room or when we're planning to go to the operating room, there's a more useful classification, and that's called the Nevis-Zinke classification that's been developed at the Mayo Clinic in Rochester in Minnesota. And that one goes as follows. So level 0 is a tumor thrombus that's limited to the renal vein, so it has not gone to the IVC yet. Level 1 is a tumor thrombus that's now in the IVC, but it's extending less than 2 centimeters above the renal vein ostium. Level 2 is a tumor thrombus in the IVC that extends more than 2 centimeters above the vein ostium, but it's below the hepatic veins. And a level 3 is at or above the level of the hepatic veins, but still below the diaphragm. So now we're still in the T3B category. And level 4 is above the diaphragm or into the atrium. Very briefly, I'll describe our personal experience at MD Anderson, and this is a bit outdated and we're working on updating this. But when we looked into our database, and I've listed the years here, we found about 600 patients. Hello? We had about 600 patients with a tumor venous invasion. This includes any venous invasion. The median age is about 60, which is within expected. We had a follow-up of about 2 years. Tumor size was about 10 centimeters roughly. Most of the patients were clear cell kidney cancer, and almost half the patients were non-metastatic. These were N0, so negative nodes, and M0, no metastatic disease. And this is an experience we reported almost 10 years ago. Most of these patients, as you can imagine, were limited to the renal vein. About 200 patients had true IVC invasion, and about 40 patients had IVC invasion above the diaphragm. These are tremendous operations. These are surgeries where complications can happen. Median blood loss is about 1 liter. Operative time on average was about 3 hours. Hospital stay was about 1 week. The complications, as you can see here, and again, keep in mind, this is from almost 10 years ago, the 30-day mortality rate was about 2.6%. Complications in the first 30 days occurred in about 1/4 of the patients, and almost about 10% of patients had complications between 30 days from surgery up to 1 year after the operation, and more than half the patients required transfusions during the surgery. The overall survival for non-metastatic patients is very encouraging. It's about 5.5 years. However, for patients who have nodal or distant metastatic disease, it's slightly over 1 year. And again, this is almost 10 years ago, and now the data will have to check it, but I suppose it will be longer given the new therapies that are available. And these are the predictors of survival that we noted. So if you have clear cell subtype, it's actually better in the setting of IVC thrombus. we've noted that patients with papillary kidney cancer,
Your dress is nice.
if they have IVC thrombus, they actually do worse. And we do not
The
know
belly.
why that is the case.
But when you stand,
I think somebody is forgotten to do the mute. Hello? So again, patients with papillary kidney cancer, they have worse outcomes. If you have grade 4 or sarcomatoid dedifferentiation, you have worse outcomes. And in addition to the tumor thrombus, if you have perinephric fat invasion or lymph node invasion, you have worse outcomes. And all these make sense. However, we still don't know why patients with papillary kidney cancer have worse outcomes. And it's something that needs to be validated and investigated further. Currently, one of our fellows is working to update this experience from 2009 to 2018 and see if the outcomes are any, hopefully, better and different. So let's go to preoperative preparation. What do we do in our clinic when we see a patient with an IVC thrombus? It's very important to do all these things here: history and physical examination, and I'll go through each of these in detail. Laboratory evaluation, MRI abdomen if available. You have to do a full metastatic workup, and there's ancillary management that has to be done as well. So what we're looking for specifically in the history and physical is shortness of breath. How much can the patient walk on a flat surface? How many flights of stairs can the patient walk up? If there is increased in the abdominal girth, that will tell us that there might be ascites, and I'll tell you why that's important later on during the talk. If there is lower extremity edema, I ask the patients generally, do they have problem putting on their pants? Do they have problem using the same shoes that they've used for years? If there is gross hematuria or not. Laboratory evaluation, we would get normally a complete blood count. The main thing we're interested in is the hemoglobin to check for anemia, and also a complete metabolic profile to check for kidney function, but also for liver function tests, which could be an indication for metastatic disease in the liver, or more importantly, if the patient has Budd-Chiari syndrome, and I'll describe that in a few minutes. And the last blood test that is very important is an INR to check to see if the liver is functioning well and to make sure the patient is not coagulopathic. The imaging modality that is preferred in patients with IVC thrombus when available is an MRI of the abdomen. It's very good technical modality because it defines the level of the thrombus well. It helps differentiate tumor thrombus from bland thrombus, which is a very important differentiation. It also shows you the venous collaterals and shows you that the patient has had the thrombus for a long time, and that's why they were able to collateralize. And it's very important to try to preserve as many of these collaterals as possible in order to maintain blood flow back to the heart. And if possible, it's extremely important to repeat imaging within a week of surgery to avoid surprises. One thing that we should not do is see the patient today in clinic, schedule the patient, a month or 2 months from now, and not do any imaging, because these tumor thrombi, I've seen them progress within a week, and it doesn't happen to everybody. The problem is we don't know who it's going to happen to. So it's very important to make sure you have recent imaging within a week of the surgery if possible. And of course, we have to do metastatic workup to see if surgery is indicated or not in general. That's generally done with a CT of the chest, MRI of the brain, and a bone scan if needed. And finally, ancillary management, we should consider anticoagulation if the IVC is completely occluded or near completely occluded, or if the patient has bland thrombus in addition to the tumor thrombus. Generally, we do not perform renal artery embolization prior to surgery, and I'll show you the only example when we do that in a few minutes. But in general, for the vast majority of patients, we do not need preoperative renal artery embolization. We definitely do not need an IVC filter prior to surgery. That will make the surgery much more technically complicated with very minimal benefits, so no need for IVC filter. The consultations we do prior to surgery in general is consultations with anesthesia, consultations with cardiology for a high-level tumor thrombus, and also with our vascular or cardiovascular surgery colleagues, depending on the tumor level, the tumor thrombus level. We have special OR suites for these types of surgeries. We generally have larger rooms for these operations in order to bring equipment if necessary, such as cell saver, so that we can suction the blood during surgery, clean it, and then give it back to the patient if needed. For level 3 and 4 surgeries, we generally have the cardiac pump available in case we need to do bypass. And we have dedicated teams also. So there's only a few urologists in our department who can do this type of surgery. And there's only a few vascular or cardiovascular surgeons who can do the surgery. And this is just by agreement between us as a team. And also, there's only a few anesthesia providers who can do this type of operation. So we generally try to keep relatively the same team together to do these operations in order to improve the outcomes for our patients. And also, we have to check with our blood bank to make sure we have enough blood products prior to these major operations. So now moving on from preoperative evaluation and management, let's go to intraoperative exposure. What do we do now during the surgery? This surgery can be done in many different ways. What I'm showing you right now is based on my own training here. This is not to say that other methods are not good. Again, this all depends on the training of each individual surgeon. This is the way I train to do it, and I've been doing this like this for many years, and I find it to be very helpful, very doable, and very safe. But again, it's not wrong to do it in a different way as long as it's safe and reliable and reproducible. So the way we do it here in our center is when the patient is supine, we always give the patient subcutaneous heparin when they come to the operating room. If the tumor thrombus level is level 2 or 3 or higher, we generally ask our anesthesia colleagues to do a transesophageal echocardiogram, and I'll show you a few videos of that later. And we prepare the patient from the chin down to the thighs in case we have to do cardiac bypass and a pump. And the way we do the surgery is through a midline incision. So that incision goes from the xiphoid to the symphysis pubis. And the reason we can do it through this incision is we have a retractor called a Thompson retractor that is extremely helpful, and I'll show you that in a second. So this is the Thompson retractor. This is the patient's head over here. The patient's feet are this way. And this is a self-retaining retractor that you could see over here. You could see the liver and the omentum over here in this type of exposure. And this is a type of exposure that you could see with this retractor. This is actually an operation that's a lymph node dissection for testicular cancer, but I just wanted to show you the level of exposure you can get without using anybody's hands. So here, this is what we could see without anybody touching the patient. You could see the IVC, you could see the aorta, the iliacs, the ureter, everything is retracted. And if something like this is available, it's tremendously helpful to do a safe operation without human retraction, so to speak. This is just to show you what we see. This is just simply a radical nephrectomy. You could see the tumor vascularity here. You could see the omentum and the mesentery is still covering. This is what you see once you open the white line of Tolt and you reflect the left colon away from the tumor. And this is what you see after surgery. Again, there's no hands in here retracting anything. This is just a nephrectomy. You can see the spleen, the aorta, the psoas muscle, and the vertebra down here after a lymphadenectomy as well. So this is the kind of exposure that will make the operation feasible and safe. So let's talk about the low-level IVC thrombi. So these are level 0, 1, and 2. Again, level 0 is limited to the renal vein. Level 1 is in the IVC less than 2 centimeters away from the vein ostium. And level 2 is between 2 centimeters and below the level of the hepatic veins. We always start on the right side, no matter where the tumor is. So whether the tumor is a right-sided or a left-sided kidney tumor, we always start by a right-sided exposure in order to expose the IVC, the aorta, and the renal arteries. And in order to do that, there's a maneuver called Cattell-Brash maneuver. And the technical term for it is a right-sided medial visceral rotation. And I'll show you what I mean by this. So when you do this maneuver, you want to open the white line of Tolt on the right side, and you reflect the colon and the hepatic flexure of the colon from right to left. And this is what the surgeon has in his or her hand here. And then you expose the duodenum, and then basically you do a full Coker maneuver to mobilize the duodenum and the head of the pancreas away from the cava. So you end up with a view such as this. And then ultimately you open the root of the mesentery all the way to the ligament of Treitz, and that exposes the entire retroperitoneum for you. Again, what you do is you pack the right colon in a small bowel, and you can pack it inside the abdomen or outside the abdomen, and that exposes the entire relevant retroperitoneum. And this is the example here. Again, you see the right colon reflected, you see the entire small bowel reflected, and this is the root of the mesentery that's been opened here in order to achieve such a retraction. And this is the view after doing a Cattell-Brash maneuver. You have the right kidney, you have the IVC, and you have the aorta over here. Again, this picture is from a lymph node dissection for testicular cancer, but this is a close-up picture, again, showing you that with this exposure, and again, this is only exposing the right side, you can see the right renal artery and the left renal artery, again, from a right-sided exposure, and I'll tell you in a minute why this is important. So we're going to talk first about the right-sided IVC thrombi. So step by step, you first identify the right renal artery, of course. The best place to identify this is in the interaortocaval space, posterior to the left renal vein. And I'll show you a few pictures of what I mean by that. What you want to do is also control and divide the right adrenal vein, control and divide the right gonadal vein, and also the lumbar veins within your surgical field. And then ultimately you want to isolate and place either an umbilical tape or a vessel loop around the contralateral or the left renal vein, also the IVC above the thrombus and the IVC below the thrombus. And again, this is the exposure. As you could see here, this is the right renal artery, and the best and safest place to find it is posterior to the left renal vein. Again, another picture showing you that you have a lot of right renal artery that you can find posterior to the left renal vein. You do not have to find it here because this is where the tumor thrombus is, and you do not want to manipulate the tumor thrombus until the renal artery is controlled. Again, another picture showing you there's plenty of space to control the right renal artery in the interaortocaval space. Again, this shows it here after being controlled with a tie and a clip. And then once you do that, you control the IVC below the thrombus, then the left renal vein, and then the IVC above the thrombus. As you've noted so far, I have not talked about nephrectomy at all. Nephrectomy in general is the last thing we do during this operation. And then what we do after controlling the entire venous system within the relevant field, of course, is open the IVC wall with a 15 blade. So that's not a sharp blade. And what I mean by that is has a very shallow surface so that you don't puncture the thrombus. And then what you do is you have to resect the IVC wall, including the renal vein ostium, because the tumor thrombus, if it wants to invade somewhere, this is the first place it invades. That's the vein ostium on that same side. And then for that, we use either the pot scissors or the reverse pot scissors or Cooley scissors, or it depends on what you have available within your surgical set. And then once we remove the thrombus, we flush the IVC with heparinized saline, and we generally close it with running suture with non-absorbable suture. Generally, we use small prolines like a 5-0 proline suture. And if the diameter of the IVC is expected to decrease by more than 50%, we could use a bovine pericardial patch in order to make up for that space. And ultimately, once we close the IVC, then we do the nephrectomy. So again, the nephrectomy is the last part of the procedure when we do an IVC thrombus. And again, showing you here, controlling the right renal artery posterior to the left renal vein in the interaortocaval space. This is isolation of the IVC above the tumor thrombus. You can see here the right and the left renal vein. And this is after the tumor thrombus has been resected. You see the surface of the IVC is clean. This is a specimen. And this is how the IVC looks like after the surgery. You could see here the suture line, and the blue suture here is the proline suture that we've used. You see the IVC itself still of a good caliber. It's not narrowed, and there's no need to use a patch in these situations. And again, if you see here, these are the clips that are on the renal artery in the interaortocaval space. So going from the right side, let's talk about the left-sided IVC thrombus. Again, it's the same exposure to start with. We do a Cattell-Brash maneuver. We move all the intestines away, and we're still operating on the right side, although it's a left-sided tumor this time. But now we control the left renal artery. And usually the space is not too much. So all we need to do is put a silk tie on the renal artery, and we can divide it later, but at least we've controlled the renal artery of the kidney that's affected. And then you definitely want to identify the right renal artery, so that's the artery feeding the normal kidney, and you want to isolate it away from the IVC. The renal artery and the IVC are going to be in close contact, and when you open the IVC to do a thrombectomy, you have to make sure your renal artery is separated from it so that you don't injure it by mistake, and basically the patient will end up on dialysis if that happens. So you want to control the gonadal vein. You want to control the adrenal vein on the right side temporarily only. Almost always when we do a left nephrectomy for an IVC thrombus, we end up taking the left adrenal gland with the tumor. So we definitely want to preserve the right adrenal gland. That's why we only control the right adrenal vein temporarily, and you can use a clamp, you can use a clip, or you can use a vessel loop, and you want to release that at the end of surgery so that the patient still has a functional right adrenal gland. Then, of course, you have to control the lumbar veins. And like I mentioned, for the right side, you want to control now the contralateral renal vein, the IVC below, and the IVC above the tumor thrombus. And generally, we use clamps the majority of the time, and we clamp the IVC below the thrombus, then the renal vein, and then the IVC above the thrombus. And then we open the IVC wall, resect the IVC wall, including the renal vein ostium, flush, close with running sutures, and again, use a bovine pericardial patch if needed. And at the end, we do the nephrectomy. So to do the nephrectomy now, we have to put the bowel back into the abdomen, because remember, we did this through a right-sided exposure, and then you do just like a regular left-sided nephrectomy. You mobilize the white line of Todt on the left side, and you've already controlled the artery, and you've already controlled the vein, because we've done the IVC thrombectomy. We have finished the dangerous part of surgery first, and now we're just doing a nephrectomy. This is a short video to show you, this is the tumor thrombus that you could see here. You can see an enlarged left renal vein. And again, you see the aorta, you see the IVC. And it's just a short video to show you the steps of the nephrectomy. Here you can see we found the left renal artery, we controlled it. Here, this is a vessel loop on the right adrenal vein that we're temporarily closing. You see an umbilical tape on the left renal vein. Again, this is the aorta. This is the right renal vein. And this is the IVC below the thrombus. So the IVC below the thrombus has been clamped. You can see it here. Now a clamp is being placed on the contralateral renal vein. This is the renal vein on the normal kidney. And now there's a clamp up here. And now you see a blade being used to open the IVC. And this is what we call a Potts scissors. And now we're resecting the IVC, including the renal vein ostium, which is present here. You can see the surface of the IVC internally. Here, this is the right renal artery that has been separated from the IVC. You see it's very close, and it's very easy to injure it if there is any amount of bleeding. And now this is the tumor thrombus. And this is the IVC wall over here. And now you see the suturing of the IVC being performed with running Prolene suture, one from each end, and then we tie them in the middle after flushing the IVC with heparinized saline. And then we release the clamps. Again, you see here the right renal artery. This is for the normal kidney. And this is how the IVC looks like after closure with minimal narrowing. So going to a level 3 IVC thrombus. So now we're talking more serious stuff. This is at the level of the hepatic veins, but still below diaphragm. We have to do the same steps of what I've already described to you, but we have some additional work to do here. Here, we need anesthesia to do transesophageal echocardiogram to monitor the tumor thrombus, to make sure we're not inadvertently causing a tumor thrombus embolization. Here, we have to also control and divide the short hepatic veins to mobilize the liver. You want to mobilize both lobes of the liver. You start by the left side, and then you do the right side in order to provide maximal rotation of the liver, so you could have exposure of the entire IVC surface behind the liver. Here, in addition, we have to do a Pringle maneuver after controlling the hepatoduodenal ligament. And then we also have to clamp the suprahepatic IVC, and this is above the liver, but still below the diaphragm. Now, this is a very important technical point. So when we're controlling the IVC above the liver, of course, we have to have a Pringle on in order to control the blood flow into the liver. However, what we can do is once you close the IVC and you're now below the liver, you can transfer the clamp from above the liver to below the liver, and then you can release your Pringle in order to allow the liver to breathe again. And that's a very important step when you're doing a level 3 thrombus, is once your IVC wall closure is below the hepatic veins, you can switch the clamp from above the liver to below the liver in order to allow drainage of the liver one more time. And you close the IVC in a standard fashion, and then again, ultimately you do a nephrectomy. And for level 4 thrombus, that's basically above the diaphragm or in the atrium. For these patients, we definitely have to have the pump ready. And then most will involve a median sternotomy and bypass with cardiothoracic surgery. And just to show you a brief video about TEE or transesophageal echocardiogram, this is an axial view over here. And you can see the tumor thrombus mobile. These are the scary thrombi because these could easily fracture and embolize into the heart. So you have to be very careful when you're manipulating the kidney or the IVC with these types of situations. This is the same thrombus. Now you're viewing it in a craniocaudal dimension or in a coronal view, and you could see it lengthwise at the level of the hepatic veins over here. This is the IVC. This is the length of the IVC, and you see the tumor thrombus, and you see the liver and the hepatic vein as well. Now, in a nice trick to reach the chest through the abdomen is you can open the diaphragm in a anteroposterior direction, and I'll show you that in a second. And in this fashion, you can actually access the pericardium and the heart in the right atrium without having to open the chest. And that's a technique that our cardiothoracic surgeons use if the tumor thrombus is barely into the atrium and they don't think they need cardiopulmonary bypass. And this is what it looks like. You have the liver over here. This is a right phrenic vein. You could see the heart over here. This is the right hemidiaphragm and the left hemidiaphragm. And again, you see these are sutures that we're using to close the diaphragm again after having access to heart. This is the suprahepatic IVC here. You can see the silk tie. This is on the left phrenic vein, and you can see the liver over here. Just a couple of slides on each of these topics. I'm going to talk about the surgical margins, predicting IVC wall invasion, management of the IVC in different scenarios, neoadjuvant therapy, butt Chiari, and ultimately pulmonary embolism. Talking about margins, when you say margins, you're looking at the IVC wall itself over here. You could see on the left, this is a nice tumor thrombus that is not adherent to the IVC wall. This one is a much different scenario. You could see the tumor thrombus is completely adherent to the IVC wall. And while we always aim to achieve microscopically negative margins, this doesn't happen every time, unfortunately. And we've actually looked into this, and in those patients who had a positive microscopic margin, most of these patients actually have a recurrence in a distant fashion, not just locally. Patients who have a isolated local recurrence after a positive margin are actually very few. And this is an indication of both the disease biology, because these are extremely aggressive tumors once you end up in this margin situation. So unfortunately, most of these patients are destined to recur in a distant fashion, and they do recur sometimes in a local fashion as well. But a true isolated margin locally is very, very uncommon. And this is our experience. About 6% of patients had a local recurrence. However, most of these patients had a distant metastasis as well. Definitely, it's a technical error to have a positive margin, but also it is a sign of aggressive biology in these particular situations. How about IVC wall invasion or needing for resection? There's a couple of manuscripts that have been described to try to help us predict who might need IVC wall resection more than you think you need to, and who might need replacement of the IVC or patching of the IVC. And some of our colleagues have done this work, and generally patients who need IVC resection are those who have a right-sided tumor, and also those who have an IVC diameter in an anteroposterior fashion more than 2.4 centimeters. And also if you have complete occlusion of the IVC radiographically, this tells you that there's a higher chance you're going to need IVC replacement or resection. How about neoadjuvant therapy for IVC? There are several case reports that have showed excellent results with tyrosine kinase inhibitors, but also there's case reports that show that patients progressed on neoadjuvant therapy for IVC thrombus. And this, so what we did is we joined forces with one of our colleagues at UT Southwestern in Dallas, and we looked into this. And what we found is only 3 patients out of the 25 patients we studied had a decrease in the level of the tumor thrombus with neoadjuvant therapy, but only one of them had a meaningful decrease of the tumor thrombus where the operation changed. And this has been validated with other studies as well. This is a retrospective study from France, only 14 patients, and only one of the 14 patients had a decrease of the tumor thrombus. Most of them had stable disease, one actually increased. And this is a study from South Korea on 22 patients, and only 2 patients had a partial response in the tumor thrombus, while the other 20 patients had stable disease. And this is the only study that I know of that's prospective that just finished accrual using a drug called axitinib to try to shrink the tumor thrombi, and we're currently awaiting the results of this trial. So in general, neoadjuvant therapy is not needed for the vast majority of patients with tumor thrombus, especially if the patient has non-metastatic disease. Generally speaking, if the tumor thrombus is resectable, we should go to surgery. We should not give the patient neoadjuvant therapy. So what about managing patients with IVC thrombus that is both a tumor thrombus plus a bland thrombus at the same time? This is a nice paper from our colleagues at the Mayo Clinic. As you can see here, the vast majority of the patients we take care of, almost 3/4, all we need to do is simple IVC closure. As you can see here, and this is the same thing that I showed you in the pictures and in the video. This is the vast majority of the patients, which is good. And rare conditions, what we need to do is put an IVC filter below the renal veins. And this is in the setting of isolated distal bland thrombus, as you can see here in the iliac veins. Now, if the bland thrombus, which is here in dark red, reaches the tumor, what we can do is remove as much as possible and then interrupt the IVC below the renal vein on the other side in order to maintain flow. However, if there's tumor thrombus mixed with bland thrombus below the renal veins, then it's probably best to interrupt and basically resect the IVC in order to prevent any further progression of the bland thrombus. And this is nice work from Mayo Clinic, published about 13 years ago. I mentioned to you earlier Budd-Chiari syndrome. Thankfully, it's a rare syndrome that we see in our clinic, but it's a very important one to keep in mind. This happens when you have occlusion of the hepatic veins from tumor thrombus, and the patients will come with abdominal pain, ascites, hepatomegaly, and the patients had elevated liver enzymes, elevated INR, and generally lower extremity edema as well. And this is what you see. So you have IVC thrombus. This here is normal liver. And this here is liver that's congested because there's tumor thrombus blocking the right hepatic vein. For these patients, we do not do upfront surgery. This is the only time or only situation where we embolize the renal artery first. Maybe we would add systemic therapy, and then we reassess the patient around 2 months later, and then we take the patient to nephrectomy if the Budd-Chiari syndrome has resolved. This is an example of a patient who had successful renal artery embolization, and then around 2 months later, you see the tumor thrombus is still there, but it retracted just enough to allow the hepatic vein to drain again, and now the liver looks normal. So this patient, we took to surgery because the Budd-Chiari syndrome has resolved. And that's the final topic I'll touch on is pulmonary embolism. And that's something that you see not infrequently in patients who have IVC tumor thrombus. And what we've actually found is that the presence of pulmonary embolus at the time of presentation does not affect survival in patients with IVC thrombus. Most of the time, these are bland thrombus because of stasis in the IVC, and these are generally not tumor thrombi that are present in the lungs. And in general, those patients we have to anticoagulate, and we stop anticoagulation around the time of surgery, and then we still operate on those patients. But what our data show is that presence of pulmonary embolism at the time of presentation does not affect the patient's survival, which is a good thing. And these are the people I work with, my colleagues from urology, from cardiothoracic surgery, from vascular surgery, and from anesthesia as well. And again, this is very much teamwork, and this is not an operation where it's only one person that's important. This is a lot of people working together to improve the outcomes of our patients. And that's all I have for you today, and thank you very much for your attention.
Wonderful, great presentation.
Thank you, Dr. Addai.
Do you mind putting my case presentations on?
Yeah. I don't know if there's any questions.
Okay. Yes. So you
Me,
ask questions first before you come to the case presentation.
yeah, let me just put it up. Can you see it?
Yes, I can.
Very good.
Okay. So you want me to go through it, or
Excuse
you
me.
want me to? Do I read it, or you want to go through it yourself?
Oh, no, you go ahead, please. Sir, you're patient, so you go for it. I'll just do the slides for you. Tell me what you want me to move the slide.
Great. Okay. So I want to see the slide. Let's see. Yes. So our first case is that of a 39-year-old female patient who presented with left flank pains of 6-month duration. She had no history of hematuria, no flank mass, and had no weight loss, no cough. She initially reported to a regional hospital where a workup found a left renal mass and was referred for a urologist consult. She presented to the urologist 2 weeks prior to surgery, and investigations that were done included complete blood count, the biochemistries, and liver function tests, which all tend to be normal. Now, contrast-enhanced CT scan of the abdomen showed a contrast-enhancing L-defining hypodense lesion in the upper pole of the left kidney. Can you move to the next slide? Yep. So that is the image of the upper pole lesion.
Okay.
Yeah.
Looks very well
That's
circumscribed, at least on this picture.
That's right. Can we move to the next slide?
Yes.
Yeah. And again, quite well circumscribed.
Yeah.
And no tumor thrombus, actually.
Okay.
Next slide. Next slide, please.
It looks very endophytic as well.
Endophytic?
I mean, it's kind of all within the kidney, it's very deep as well. It's not like you see a normal kidney and then you see a tumor come out of it.
Okay.
Yeah.
Okay. Great. Next slide, please. So this patient had a right radical nephrectomy.
I mean, left one, right? Left radical?
That's right.
Yeah.
Sorry.
So it was it done open or laparoscopically?
We did open radical nephrectomy. Yeah.
Okay. And what's your approach for these, Dr. Addai? How do you do the surgery? What's the exposure? Is it supine? Is it flank? Is it subcostal or?
Yeah. So we do midline.
Okay.
And go through the midline. We go through we do the cattle brush maneuver. Yes. So usually we don't have the Thompson. Is it a Thompson?
Yeah, the one
retractor?
I use is a Thompson retractor, but there's many others. Depends on which hospital,
That one is great because we have to use the Diva.
Okay.
And you have so many hands around it. It's quite difficult. I mean, being able to identify the structures easily without that.
No, I agree. It makes it for a difficult surgery that way. I totally agree.
Always we struggle with it. Can you go to the next slide? So we hardly get patients with small renal tumors, which include partial nephrectomies. But we wanted a situation where if we had brought a case with a small tumor, we wanted you to demonstrate partial nephrectomy for a 4 cm renal tumor and whether there were any pitfalls to be wary of. But since you didn't see this earlier on, I'm sure you want to move on to the next.
Yes, so
that one involved, the next case presentation involves a tumor thrombus, which goes in line with what you have just discussed.
Yeah, how big was the tumor in this particular patient?
This was this was about 6 cm. It was 6 cm.
6 cm. Okay. Yeah, I mean, this is and as I mentioned, I would think of this tumor as an endophytic tumor. It's very, very well circumscribed. But if the patient has good kidney function and is otherwise healthy, I would not do a partial nephrectomy on this patient.
Okay.
There are a lot of people now in the scientific community and on Twitter and other means that are showing pictures of partial nephrectomy on 10 centimeter tumor, on 15 centimeter tumor. And my way of thinking of it is just because partial nephrectomy is possible does not mean that we have to do it. So we have to carefully pick the patients we do partial nephrectomy on. So of course, if it's a 4 centimeter tumor, we should try to do partial nephrectomy. If it's a 2 centimeter tumor, we have to do partial nephrectomy. But what makes me worry is people doing partial nephrectomy on very ill-defined tumors that are large, and those patients have a normal other kidney, normal kidney function, and no comorbidities. I think it's dangerous to do partial nephrectomy on everybody that comes to our clinic. I think that's not the right approach. We have to select the patients who we could help. And just because partial nephrectomy might be doable doesn't mean we have to do it for every single person. We should definitely do it for small masses, but for the large masses, you know, T2 or suspected T3, if the patient has contralateral normal kidney and normal renal function, we should not do a lot of heroic partial nephrectomies unnecessarily. So with this patient, I would have done a radical nephrectomy if her kidney function was normal, just like you did.
Great. Can you go to the next slide then?
Yep.
So this is a 32-year-old man who presented with a 2-year history of painless intermittent total hematuria and left flank mass. His lower extremities were grossly swollen, worse at the thighs. He had difficulty mobilizing with severe low back pain, and he was anemic and required 3 units pre-op. Can I see the next slide? Yeah. A CT scan of the abdomen showed a well-defined, heterogeneous, contrast-enhancing left renal mass measuring 13.9 by 15.6 by 17.7 centimeters, quite huge. And there was extensive tumor thrombus noted within the left renal vein and infradiaphragmatic IVC. So this shows, but there was no tumor metastasis in the lungs. The lung folds are clear. Can you go to the next slide?
Yeah.
Yes. Yes. So that's a huge tumor.
It's a very large mass.
That's right.
And I can see the tumor thrombus as well.
Great. 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 So next, yes. So this patient had surgery done. It has not been our practice like in your case where the thrombectomy is done before you do the radical nephrectomy. We attempted to do the radical left nephrectomy and to follow it up with the thrombectomy, but attempts at the thrombus removal with Fogarty catheter failed due to the friable nature of the thrombus and its invasion of the IVC wall. And then we had plans to resect the affected segment of the IVC and replace with an interpositional graft. But we had to abort it on account of poor hemodynamic status intraoperatively. Next slide. And so this is the surgical specimen. Next slide. Because he had to abort the thrombectomy, we sent him back to the ward. And then on the ward, we realized that gradually the lower limb edema swelling resolved. And the patient was now having collateralization of the veins, said that you could see prominent veins on the abdominal wall. And the patient this time could mobilize with less difficulty. And we did a post-op CT scan of the chest and abdomen that showed the subdiaphragmatic tumor thrombus invading the walls of the IVC and extending into the right renal vein with reduced function of the right kidney. And this was the report from the CT scan that showed almost the same thing I just said. Next slide. So we asked these questions. Can you share your experience with us on how this patient should be managed going forward? Though we've gone back in and done thrombectomy for this very patient and has been discharged. But we wanted to know how you would have managed this patient.
Yeah, I would have done the IVC thrombectomy first because that, based on what I've just described, that's the more dangerous part of the operation. And then what I worry about if we do the nephrectomy first is that in order to reach the renal hilum, reach the renal artery, if you're doing it from the left side, we have to manipulate the kidney, retract the kidney a lot, and I worry about tumor embolization. That's why the video that I showed very briefly, that was a left-sided tumor, but we're addressing it from a right-sided approach because the focus of the surgery for these patients is always the IVC first. So that's how we think about it. First thing is controlling the renal artery of the affected kidney, and then IVC thrombectomy. And once we clear the tumor from the IVC and the IVC is back to normal, then we do the nephrectomy. We have as much time as we need to. If the patient is unstable, we can always stop the surgery and come back for the nephrectomy, but at least we know the IVC is cured. And we know that the blood flow is reinstated. But we pretty much always do the IVC first. The only time we do the nephrectomy first, which I've only done maybe once or twice, is if the tumor is so huge that we cannot reach the IVC and we cannot operate on the IVC. But these are not very common situations. So whenever we can, the main focus is the renal artery and IVC, and then the nephrectomy comes at the very end. But sometimes it's intraoperative assessment as well, but generally that's our preferred method to do this. Now, can this patient be cured? It's really hard to know because now the patient has invasion of the contralateral renal vein. And these are very difficult situations because generally when that happens, the tumor will be very adherent to the endothelium of the IVC and the renal vein. And you can remove tumor, but it's hard to achieve negative margins microscopically in the situation. And this patient is at a high risk of both a local recurrence plus a distant recurrence too. Now, if I may ask, what was his histology from the pathology report? What type of tumor was it?
We're waiting for it. We haven't had it yet. This was done like 2 weeks ago.
Okay. So for the options of chemotherapy, there truly isn't true chemotherapy, but there are options for immunotherapy or TKIs or tyrosine kinase inhibitors or combinations. And it all depends on what you have available in your hospital. So what are the drugs that are currently available in Ghana or available in your hospital for kidney cancer? Which therapies are available? Do you have an interferon? Do you have sunitinib? Do you have, what drugs are available now in your hospital for kidney cancer?
We don't, actually, we don't. But oncologists are able to arrange for it to be supplied once the patient has the financial wherewithal to acquire them.
Yeah, but if they do have the financial means, do you know what drugs are available by the oncologists? Or in the,
I think they have
in general?
the tyrosine kinase inhibitors.
Tyrosine kinase, okay. I mean, we know from our data and from other colleagues as well that the tyrosine kinase inhibitors generally are not very effective in controlling tumor thrombus. So if that's the only option, then this patient is not going to be cured, unfortunately. And the best opportunity for a cure is surgery for these patients with tumor thrombus. But I understand it's not as simple as that. But the best chance for these patients to be cured is to have an operation if it's technically feasible.
Yes.
Now, the
last question we heard,
yeah, it's very worrisome.
That's right. That's right.
What histologies are you finding most in your series? So these patients that you've mentioned from 31 to 40.
Most of them are the clear cell RCC.
Okay, and any family history that you might have, anyone, or it's just not, it's difficult to know?
These are sporadic cases. We haven't really picked even 2 family members before.
Okay.
Yeah.
And is this something that you see in your hospital only, or is it a trend across Ghana in general?
I think it's a trend in Ghana in general. Dr. Matthew Che is with us on this platform. He has a similar publication, and we compared our age range with his, and it looked almost the same.
Okay.
And I'm sure he wants to say something about that.
I mean, we have to think.
Accra.
Yeah. I mean, we have to think of genetic factors, but we also have to think of environmental factors that the population might be exposed to.
Yeah, if I can make a point, sir.
Yes, Dr. Che.
Yeah, agree. Thank you very much. Yes, you. So probably the age is more like maybe our life expectancy may be playing a role on us. Because in other words, of course, our mean age, we made progress. We are now probably 60, 65 years as our life expectancy. So there's a large proportion of our population is within that age group. So it looks more of probably our age structure, than maybe the genetic aspect. Because we don't have any particular risk factors, no family history. Of course, our familiar trees sometimes are difficult to tell. But it looks more like they are sporadic. But I'm thinking maybe it's because of the age bracket is the probably larger population. Maybe that's why you are seeing them that young. That's what I would say.
I mean, I would be, and these are all advanced disease, I assume, right? Because these patients are being discovered because of symptoms, or?
Definitely.
Yeah, that's extremely worrisome. I agree with you. I don't have a good explanation for it. I mean, the 2 things that come to mind, as I mentioned, is family history or genetics, or if it's a sporadic, then environmental exposure to some agent of some sort. Do they have anything in common as far as what they do for a living? What kind of job do they have?
I may have to do that sub-analysis. Nothing, no side trend actually came up easily for us to just take a finger on.
I'm happy to look at any data if you would like me to in the future, just to see if maybe you have another set of eyes, maybe a different perspective from an outsider. I'm happy to do that if you would like me to. Just, you have my email, feel free to reach out for me, please. But I agree with you, that's very worrisome. Normally, when we have patients who have kidney cancer, the recommendation in the US is to send them for genetic counseling if they're younger than 46 years old. Just because they have a higher chance of having a familial syndrome, although the vast majority of them do not. And it might be just simply because we haven't found the syndrome yet, or we don't know enough. And there's definitely a lot we just don't know yet. But I agree with you that it's worrisome that people at this age group are having presentation with very advanced disease. Now, there is a type of kidney tumor that we see here in our African-American patients who have sickle cell trait called renal medullary carcinoma. Is that something that you see in your hospital? It's an extremely aggressive type of tumor. Patients generally present with metastatic disease, especially to lymph nodes, and it happens almost exclusively in African-American patients.
So far, our histology has never come up with such a diagnosis.
Okay. So it's the
It's not
usual
something-
typical, like a clear cell or a papillary.
The series that we published, about 90% were renal cell carcinoma, the clear cell type.
Okay.
Yeah.
Okay, that's good to know. Very good.
So the floor will now be open for questions and contributions from the participants. And if you are muted, you can now mute your microphone. Or you want to
thank you very
raise
much, Dr. Arhin. Yes, thanks for the presentation. Yeah, I think we have had a lot of challenge getting the cardiothoracics to help us with the presence of tumor thrombus.
What was the question, Dr. Addai? I'm sorry, I could not hear well.
May not be that important. There's no point, directing resources to achieve
the
the kind of surgery that is. You can hear me, please.
Yes, I can.
Yeah, that we have. So getting them to direct the resources to be able to deal with these patients has always been a challenge. We don't get the support that we need, because they don't take the life expectancy that much. So I'm happy to see the report that we are getting almost 5 years, survival after this intervention. Maybe that could encourage us to push them a bit further. But we make all the investigations, we make all the echoes, but when it comes to the rare surgery, they never get us the hand. And that has been our challenge.
That's rather unfortunate. In the case that I just presented, the IVC, we had Dr. Ocho, the cardiothoracic surgeon, joining us and playing a key role in getting this thrombus out. And so he is quite happy to collaborate with us. Even in the worst scenarios, we want to do a trial and see what he can do about it. And so maybe
so it depends on the level. I mean, as I said, if it's something minimal level, 1 or 2 weeks, so that we do it without their consent.
Yeah.
But if it's high up, then of course we need them, and we have to defer to the judgment.
Yeah, once you get the level, like high level 2 or level 3 and level 4, of course, you need to collaborate with your cardiovascular surgery colleagues for sure. And there are some papers in the literature that have shown, associations with improved outcomes if there is multidisciplinary teamwork compared to just one surgeon doing everything. And of course, as urologists, we are trained to do these procedures, but generally for high-level thrombus, we always work with our cardiovascular colleagues. I think it's the safest for the patient, and we have them. They're available all the time, and we always plan these ahead of time with them. We, they meet the patient too, and we work together very well. They know what we need. I know what they need, and it's a very good experience to work together with them.
There's a question I wanted to ask. If the tumor thrombus invading the IVC wall, at the level, as in this case, the right renal vein was involved in the tumor thrombus. If you had to do an interposition graft, how do you take care of extending it to the renal hepatic vein? If you should get to that level, how do you reimplant these veins back into your interpositional graft?
I honestly
in order not to compromise the function.
Yeah, I have never been in that situation before, because generally we try to avoid replacing the length of the IVC with a graft, because these grafts unfortunately have a very high rate of failure. They, especially in the venous system, because they end up having a bland thrombus and clotting off. The only time I've done a venous graft was for a retroperitoneal lymph node dissection, and it was only for an infrarenal IVC. It was not for a suprarenal IVC. This graft is still patent, miraculously, but most of them actually just on the venous system, they clot. And when that happens, the right renal vein will clot, and then the patient will go into renal failure and dialysis. So you can implant the renal vein into the graft, but there is a very big possibility the entire graft might clot off, and if the patient has had the chance to collateralize, then that's great. If not, then that becomes a problem by itself too. So in general, we try to scrape off the tumor from the IVC wall, try to preserve as much IVC tissue as possible, and then as much as we can use a bovine pericardial patch, which works great. And you can make a tube graft out of that too if you need to, instead of using artificial like PTFE or whatnot, because these have a very high chance of clotting off when you put them in the venous system, compared to the aorta.
I see. That's good to know.
Now on the left side, it's a little bit better because on the left side, as you know, the kidney can drain into the adrenal vein, the lumbar vein, the gonadal vein. But on the right side, like you mentioned, it's a problem because it cannot drain anywhere else. Yeah.
Great.
Yes, sir.
And any other comment from the floor? Questions? Dr. Amwa, are you there? You can please unmute your microphones so that you can ask questions.
Yeah, I think my overall impression has been a wonderful presentation, but I would just want to ask him, from what we did, despite the fact that he clearly stated the point that because of thrombus migration and the fact that manipulating the renal malignancy would trigger this, is this surgically suicidal? What we did, was this surgically suicidal for we haven't tackled the tumor first before, yeah, the nephrectomy first before later on going to do the thrombectomy or the cavotomy?
No, I don't think that the invasion into the renal vein happened because you did the nephrectomy first. That's not what I meant. What I meant is I worry that if we do nephrectomy first, the tumor can migrate into the lung or into the pulmonary artery and the patient will have cardiac arrest. That's what I mean. I mean more of an acute intraoperative event if we manipulate the kidney. What happened to the right renal vein, that's basically tumor biology. It's not something that anyone did wrong. So again, what I worry about intraoperative tumor migration immediately during the nephrectomy, migrating into basically from the IVC to the atrium to the pulmonary artery and resulting in intraoperative death. That's what I refer to. Now the tumor going into the right renal vein in this patient is because the tumor is extremely aggressive and that's what it wanted to do anyway. But it's going to be very difficult, I think, to go back into the abdomen now, 2 weeks post-op, and doing the IVC thrombus. So it's something that I'm sure you will have to discuss with your cardiovascular colleagues to see if it's even possible to do, or possible.
No, Jose. Jose, that surgery has been carried out. We did it last Sunday.
You mean the second operation?
The second operation, yeah.
Uh-huh.
We went in and I wanted to show the pictures, but I couldn't load them in time. But we were able to open the IVC. Yeah. Unfortunately, most of the thrombus was the blunt type, just clots. Yeah. Clots in the inferior vena cava from the common iliacs to the infrarenal segments of the IVC. Okay. And basically, we were able to, as it were, remove them, and then we did the irrigation with heparin saline. And the patient has been discharged home about 3 days ago, and he was in good health when he was discharged. So the surgery was done last week Sunday, and we were discharged him on the Wednesday of the preceding week. And got it.
And then the renal vein on the right side was okay. Was there a tumor thrombus in it, or was it bland thrombus?
It was a bland thrombus.
Okay.
So we were able to maneuver it out.
Okay.
And he recovered quite very well and was discharged. Yeah.
And then the next, we'll just do a follow-up with the CT scan in maybe 3 months or so, just to make sure.
That's right. That's right.
And then do you discharge those patients on any anticoagulation because of the brain thrombus, like aspirin or anything else?
Yes, we gave Clezid and Enoxaparin.
Okay.
We gave Enoxaparin, and when he was going home, we put him on the tablet form of Enoxaparin.
Okay.
Yeah.
Yeah, that's definitely something that we do for a month.
But for such a patient, how long should we anticoagulate?
I would do it generally for 1 month. I would do something like that. And then I keep them on aspirin for life, baby aspirin. I do not have any data to support that, but that's what we've agreed on with our vascular surgery colleagues. So like you did, we use like real anticoagulation for a month after surgery, and then aspirin for life afterwards. Again, we don't have any prospective data to support that, but that's what we've been doing.
That's quite instructive. Any other questions or comments from Dr. Morton? I see you. I see you joined us quite late, but maybe you may have something to comment or two. Dr. Morton, please unmute your microphone if you want to make a comment. Okay, I can't hear Dr. Morton. Minta, are you there? Dominic? Most of the microphones are still muted. Can it be unmuted so that we can hear you if you ask any question? Okay.
All right. Okay, Dr. Addai. Any other questions before we go? Hello? Hello? Dr. Addai?
It looks like Dr. Addai just
You
disconnected.
logged out? Okay, well, I think this is the end of it then. Thanks, Katie, for arranging this. And I would like to thank Dr. Addai for, hosting me as well.
Yeah, thank you so much. This was a great lecture.
All right, very good. Everybody have a good day and take care.
Yeah, thank you.
Bye-bye.